Welcome to the new Ortho Info podcast, a monthly series where board-certified orthopedic surgeons provide in-depth answers to frequently asked questions about bone and joint conditions, treatments, injury prevention, and more.
Welcome to the Ortho Info podcast. I'm Dr. Sharif Bashea, a shoulder and sports medicine surgeon with the Detroit Orthopedic Institute. Each episode for the Ortho Info podcast will answer some different questions, and this one is like no other. We have two of my dear friends on, and we're going to talk about orthobiologics, which is a very hot topic these days in medicine. You'll see it on every corner that there's something new going on with something that's biologic that's going to help us. So I have two world experts here and also two dear friends of mine. I have Dr. Don Buford and Dr. Scott Sigman. Dr. Buford is a sports medicine surgeon who also founded the Texas Orthobiologics in Dallas and is the president of the Interventional Orthobiologics Foundation. Dr. Sigman is a sports medicine surgeon at the Orthopedic Surgical Associates in North Chelmsford, Massachusetts, and he's one of the earliest adopters of a bioinductive implant that we both use for rotator cuff repairs and also the founder of OrthoLaser. So welcome, boys. How are you guys today?
Awesome, Sharif. Great to see you, brother.
Yeah, good to see everyone.
It's great to have you both on. I'm going to just jump right in. I mean, Scott, why don't we start with you? Tell us a little bit about your voyage to biologics and different things like photomodulation and what got you away from the traditional norms of just like hammers and nails in orthopedics.
Yeah, I like to say, Sharif, my first 20 years in clinical practice, I was a mechanic, right? I just looked at things that were broken, whether it was an ACL or rotator cuff or whatever, even broken bones. We use plates, we use screws, we use anchors, we use sutures, and I was always we're just going to fix the mechanical problem. Really, in the last 10 years, I really have been relying much more on my biology degree from Tufts University. I really have incorporated biology, and I think that the way I look at the human body is that every cell has enough DNA to recreate our body, and so why is it that certain things stall when it comes to these inflammatory conditions or these traumatic conditions? Why can't the body always heal? And so combining a mechanical approach with adding in biology to try and stimulate a healing process has really become a passion of mine.
And Don, what's your answer to that same question?
Yeah, I was fortunate enough to be in England about 20 years ago at a sports medicine meeting and was exposed to somebody doing something called platelet-rich plasma back then, and had never heard of it, never seen it. And at that same visit was also exposed to ultrasound at the same time. And so I came back stateside with those two things lighting a fire in my brain about, what are these two things that seem to make so much sense and seem to be a direction for the future that I just was kind of driven to investigate them further.
All right, let's level set out of the gate. When we say the word biologics, I think I know what the meaning is, and I know you guys each think you know what the meaning is, and I wonder what our listeners think. But Donnie, how would you define the word biologics?
Well, I think the simplest way is anything that we can do that will affect our human biology, and most of the time we're trying to stimulate a healing response or support a healing response. In some cases, maybe even suppress a response that we don't want. And these can be injectable things that we create from using our own blood, our own bone marrow, our own adipose tissue. These can be things that stimulate the body in other ways, with photobiomodulation or shockwave, things like that. There are even manufactured things that we can use surgically that stimulate biology as well. And I would consider those broadly as biologics that can augment the response. And there's some amazing implants that have come out that are not just metal or plastic anymore. They're actually either bioinductive or bioconductive. And I think would broadly fall into the category of biologics as well.
Scott, do you have anything to add to that?
Yeah, conceptually, the idea is that, again, the human body has an incredible ability to heal itself. And what we've done previously is we've just sort of done a mechanical thing. If we push the tendon onto the bone, hopefully it's going to heal. If we push the two ends of the bone together and we squeeze it together, then the bone's going to heal. So what we're doing with all of these other things is we're stimulating the human body to create a healing response, and perhaps maybe even take something that's been in a stalled environment, like why is it your Achilles tendon hurts so much? Because there's not blood flow to the area. So we can add biologics such as shockwave therapy, as what Donnie was saying, or Photobiomodulation therapy for our listeners, that's basically using light, the energy of light and near infrared light to create a cellular mediated healing response. And so it could be things that are injected. It could be the patches that Donnie talked about. Now there's some really cool new anchors, for example, that are bioinductive as well. So anything we can do to stimulate the body to heal.
So I think it was Don that just said hopefully, or no, I think it was you, Scott, that said hopefully it heals. And a very smart business person once taught me that hope is not a strategy. And what strategies can we use now that we have these different ways of techniques? And I think we've gotten stalled as orthopedists in a sports medicine and in any type of orthopedist with techniques. Everything was technique driven. And then I think now we're looking at different things. We're talking about biologics. We're talking about nutrition. We're talking about these things that are outside the box, so to speak. But are they really outside the box, or are these things that maybe we've overlooked over the last 20, 30, 40 years? Scott, why don't you take that one?
I love having this conversation because I think sometimes we forget that we're a species on a planet, right, that has thrived. And what's on our planet? We have gravity that tries to pull us down, right? So we need strong muscles to stand up. We need to eat the right things so that we can have the nutrition to move around. We are under a sun with visible light that creates biochemical reactions. So, the point being is that it's not just a shoulder that we're operating on or just a knee, okay? It's a human being that has all of this physiology. So we need to think about all of the aspects, the holistic aspects of the entire event, whether it's injury prevention, nutrition around surgery to give the nutrients that we need, adding the biology to create a healing response, putting some laser in afterwards to create healing, and most importantly, make sure our patients aren't in pain, right? That's one of the other things that I think really helps the healing process, is to minimize that pain experience that we've really become very good at.
Don, anything to add to that?
It's going to be hard to say it more elegantly than Scott, but that's really the core issue, is we're moving away from just becoming carpenters into becoming much more upstream. And I think ultimately the future, and we'll probably get there in this conversation, the future is going to be much more about prevention and affecting things before they become structural problems.
Absolutely. So let's jump forward, like you just said, about the future. But before we get there, let's talk about now. What biologics are you utilizing in your clinics? And I want to break them down into, I hate to use the term stem cell because it doesn't mean anything. And I mean, many of our listeners will say, what do you mean it doesn't mean anything? And I think maybe we can explain that a bit. And then let's talk about PRP, and then bone marrow aspirate, and then growth factors and peptides. So kind of let's go through, what do you do in your clinics, and maybe walk us through why you use each for what. Don, why don't you take that?
Sure. So the number one, what would be considered a biologic that I use in my clinic right now is platelet-rich plasma. It's made from drawing the patient's own blood. We draw a relatively larger quantity of blood. We put it through a centrifugation process that allows us to layer out the different components of blood and to capture the layer that has a lot of the biologically active agents in it. And that becomes our concentrated platelet-rich plasma. It truly is a drug. It's a biologic drug. And the reason why that's the number one thing that I use is because that's where we have the most clinical science at this point. So it's really no more complicated than that. Now, that doesn't mean we're not investigating and exploring with PRP for applications where we don't have a lot of science with continued studies. But right now in practice, that is the one that I think, if you look across the internet, where we have the most data to support using it across various orthopedic applications. The number two biologic I use is bone marrow concentrate. It's another autologous biologic, meaning it comes from the patient's own body. We get the bone marrow from the iliac crest, which is a kind of a central axial skeletal bone, because the concentration is high there. But the key is what you said, Sharif. There are things called mesenchymal stem cells in our marrow. There's also hematopoietic stem cells. That's where a lot of the components of our blood are made, also from bone marrow. But back in the day, 20 years ago, we used to think that injecting these things, these stem cells would become whatever they're injected into. So if we inject into tendon, they're going to just become tendon. We inject into a joint, they're going to become cartilage. And we've learned now that in the vast majority of cases, these cells are actually better thought of as little factories that produce a lot of other biologically active things, in addition to sending out the signal to attract more activity to that site. And so the reason why that's the number 2 biologic I use is because that's where we have the second most evidence. And frankly, we have the most evidence to use bone marrow concentrate around joints, around marrow diseases like avascular necrosis. There's a fair amount of evidence for using it in degenerative disc disease. And those are the two. Now, there's another category with adipose tissue that I don't use in my practice, but it's another very viable autologous from the patient biologic that's used very, very commonly across the world, really.
Scott, how do you want to answer that?
So I think one of the things we should talk about for our listeners is why, the word STEM is a 4-letter word when it comes to ideas of orthobiologics. In order for us to use these products, they have to have at least an FDA on-label indication. So the on-label indication for platelet-rich plasma is to augment a bone graft. So that's the way in which it was typically brought out. What we figured out for our listeners is that if you do it right and you take that same stuff and then you put it into somebody's knee joint, it really can provide significant pain relief. But it's actually an off-label use of the PRP, which we all discuss with our patients when we sign them up for these procedures. And the same holds true for bone marrow aspirate, but there is no on-label indication for stem cells in orthopedics at this moment. There are investigative studies that are occurring, and you can get them if you're involved in one of those investigative studies. So the point being, yes, I'm a PRP guy. Thank God for Donnie Buford. He does all the science. He does all the research. I look at every publication that Donnie does so that I don't have to, and then I can then relate that to my patients, and we use it routinely as well. So in the office setting, that's where we're using the PRP as well.
So we talked about data, and I think that's so important because, as you said, Scott, when Don says something, I listen because it's correct and I know it's vetted and I know it's important. And why that's important to me when I listen to him is because I want to offer something that is appropriate for my patients. And what I mean by that is there's a lot of places, and I don't want to be mean to other people at this time, but I think it's important for our listeners to know that there are differences in what they're getting. So how would you educate the patient to say, well, the guy down the street is doing stem cells and he's buy one, get one free. What does that mean? And are you getting the same stem cells over there? When that's why I don't want to use that term, because when you say stem cell, you have no idea what they're really selling. And how do you educate the listeners so that they're understanding what they're getting, making sure that they're getting a value for the money they're putting in? Don, how do you answer that to your patients?
Yeah, I mean, that's a conversation every day. And one of the things to my orthopedic colleagues, these visits, if you're really going to spend time and think it's appropriate to discuss biologics, these visits are not 5 or 10 minute pre-op or post-op visits. You're going to spend 30 minutes educating someone because it really is important, in my opinion, to have them on the same page with you and to not be expecting to turn their 65-year-old knee into an 18-year-old knee in 2 weeks with a stem cell injection. And so what I tell patients to keep them safe, and I encourage them to investigate, but I want to give them some boundaries. And number one is, if it doesn't come from their own body, then I think at this point we have to set that aside. Not only because we don't have a lot of literature on stem cells that don't come from our own bodies, what's called autologous, but also because in this country, in the United States, any allograft or not from our body source of stem cells doesn't have any approval at all and would typically be in violation of FDA regulations. So any clinic, any clinician, any salesperson, any website promoting stem cells where they tell you, yes, we draw them out of a bottle when you come in, I would just set that aside and without throwing too many stones, because one day that may change, but not right now. But without casting aspersions too heavily, I would go to the next clinic, because that's one of my screening questions that I tell patients to ask in their search is, where do you get your stem cells? And if it's not from your own body, then just keep moving, because that's really what we're allowed to do in the US. And that's really where the science is, more importantly, and the safety.
So, Don, let's talk about with PRP, since you said that's what you do the most. Mm-hmm. We've discussed how not everything is created equal. What about PRP? If you're talking to if we're talking to the listeners, are we telling them to look for certain things and ask certain questions? Is there a certain amount of platelets we need to make them work? And then we can talk maybe a little bit about, is there white cells in it? Is there not white cells in it? Does that make a difference? So why don't you take that one?
Yeah, we've learned a lot as we continue to study platelet-rich plasma. And one of the things that we've learned over the years is that the clinical response seems to improve as we give a higher dose, right? So, back in pharmacology class, back in medical school, we had a class in pharmacology, or at least a section of a class in pharmacology where we learned about the dose response curve. And that's what ends up in drugs that get released into the market, right? There's a bottle on the back of the bottle that says take 1 to 2 pills every 4 to 6 hours. That is the kind of information we're trying to develop for PRP for different orthopedic indications. And it's not an easy task, let alone for the clinician, but obviously it's a mountain to climb for the patient, because they aren't going to know all of the different kits that a clinic or doctor could purchase. They aren't going to know the platelet recovery percentages. They won't know the dosages. And so as I try to educate my patients as they're searching on their own, one of the single most important things to ask is, how much blood do you draw? Because that's that is the single most important clinical factor that any of us can affect on the day of a PRP procedure. I can't really manipulate the patient's platelet count to any significant degree. Other than making a choice about a particular kit, the single most important thing that determines how much PRP I'm going to give someone, or the platelet dose, is how much blood I draw. And there are kits on the market where you draw 8 cc's of blood and it's called PRP. There's kits on the market where you can draw 120 cc's of blood and it's called PRP. But I'm here to tell you the clinical benefit of a PRP made from an 8 cc blood draw is far, far inferior in virtually every situation compared to the PRP made from 120 cc blood draw. And so at this point, we don't really have any data suggesting that we can be too high. Theoretically, maybe we could be, but with the commercial kits we have available, and even the places that make PRP on their own, we know that we can draw a relatively large amount of blood to make PRP. And the problem is, in the literature, and what makes it so difficult for all of us, is when these papers are published, the title just says PRP. And in a lot of these papers, it doesn't really get into any more detail throughout the entire paper about how much blood was drawn, what the platelet count was, what the dose was. And so now, as we get more sophisticated, every paper that's submitted to a journal where it discusses PRP needs to have those quantifying numbers so that we can really compare apples and apples. It'd be like going to a car convention and saying, I've got 6 cars in the back, but you don't mention the make, the model, the year, the color. All you know is you have cars. So just saying it's PRP is far from enough to say anything positive or negative about it. If you're going to really be in this wholeheartedly and help people, then I think you have to get a little bit more granular now that we're this far along in the clinical research. So,
Hey, Donnie, how about time of day when you're drawing? Is that affecting the platelet levels? How about nutritional status? So they'd be on nutritional
100%.
status prior. So give us some information about that.
Yeah, 100%. Activity level, all of those things matter. I'm just getting started on a nutritional study. It's obviously apropos that you mentioned it. All of those things, a single person's platelet count will vary during the course of the day. And the normal range for humans is like a 3-fold range. It could be as low as 150, just to use a number, or as high as 450 and still be normal. And your platelet dose will vary depending on what time of day you draw that blood. Now, the good news is the results aren't so pigeonholed that if you're at 150 instead of 180, it's not going to work. But there are certain things we know that are better. And so, again, clinically, though, the biggest impact will come from drawing another 30 cc's of blood compared, I think, at this point, with what we know, compared to time of day, compared to maybe even nutrition, unless someone's chronically a disadvantaged state with nutrition. But we understand that that's a variability in it, and that's why we want to have platelet dosing, but it's rarely an absolute number we're looking for. We're looking for a trend and a range to be higher.
I mean, you've just told us so much, and I think that's important. And if there's something that the listeners took away, is that last 5 minutes, because I think your example of talking about, we have 6 cars. I mean, you have no idea what they are, and yet we're selling them, and you're just going to buy them sight unseen. And so I think there has to be a little bit of understanding of what you're getting. And I think there's some really good salespeople that can make the sales of those 6 cars that are sight unseen. And same with PRP, but I think our listeners deserve the value of what they're going to spend for these, because unfortunately insurance does not cover them, and therefore it's something that you'll have to do the research for. While we're still in the clinic, we're still talking about clinic before we move to OR stuff. What about peptides? It seems to be all the rage these days. I probably get 5 questions a day about peptides. Scott, how often are you seeing it being asked to you, and like, what's your advice to these patients?
Yeah, I mean, so I don't have a lot of clinical experience with peptides, but one thing I will say is that a peptide is basically a protein that's got a bunch of amino acids. And if you put it in your mouth and put it in your stomach, the first thing that's going to happen is it gets broken down into amino acids. So if you're going to use peptides, probably the only way that they could probably be used is intravenous, to be honest with you. So what I actually talk to the patients, when I do talk about protein, it's about the essential amino acids, right? Those are the key blocks that are required to get a really good healing response in our perioperative period. So I make sure that our patients are on essential amino acids in advance of their surgery and then for a period of time after the surgery as well, but very limited clinical experience or professional opinion on peptides.
How about you, Don?
Yeah, so the true story on peptides in the United States, as I understand it right now, is this. There are some peptides that are approved by the FDA as drugs. Those are things we know most commonly as semaglutide, Wegovy, Mounjaro, things primarily for medical weight loss applications.
Insulin.
Insulin, there's another one, maybe the biggest one, yes. The peptides that are commonly talked about in gyms and on podcasts and in orthopedic applications like BP157, TB500, things we get asked about every week. Those have 0 approvals right now in the United States for any clinical indication. So it goes back to what Scott said earlier. We can, as physicians, we can use a drug that is on the market for a legal reason. We can use it off-label as long as we don't do something absolutely ridiculous with it, okay? But we can use most medications are probably used off-label in some aspect. But peptides that don't have any indication, and what I tell patients is if there's no on-label indication, I can't use it off-label. That being said, I think there's tremendous promise with them. Insulin works, right? Semaglutide works. So there's tremendous promise. They do have effects. You have to inject them, or like Scott said, or IV, or some other mechanism of delivery. But right now, not only do we have this huge regulatory burden where nobody's got them approved for an indication, we also have a lack of clinical research.
No, I think that's a conversation that I think I have, like I said, 5 times a day, and I answer it very similarly where I say, I just don't know. I don't think there's enough data for me to be as confident as I am with the procedure I want to do for you, with the protein or the protein that you need to eat and the nutrition that we have PRP, we have BMA, we have all these other things, but peptides are this new word. Like you said, they're very popular at the gym and people come in and ask the questions. But now let's kind of transition from being in the clinic to let's go to the OR and talk a little bit about bioinductive implants. And I know Scott is all over talking about how to fix an ACL without fixing an ACL and how to fix a cuff without fixing a cuff. And we're talking about the rotator cuff in the shoulder. So Scott, why don't you take us down your biologic history and tell us where it started, how it started, what's been effective, what hasn't? I mean, have you had any where you tried something, you're like, don't love that, that type of thing? Give us your history, your journey.
Well, the three of us were some of the earliest users of the Rotation Medical implant, which is now the Regeneten implant. But, it was rotten tomatoes. I mean, it was in 2012 or 2013 when we started doing this. People are like, what are you you're taking cow collagen, you're putting it over top of a rotator cuff. That's crazy talk. But then, we persevered and we were seeing really, amazing results that we hadn't seen previously. And then the data started improving. And then, for our listeners, about 2 months ago, the American Academy of Orthopedic Surgery put out new clinical practice guidelines for rotator cuff augmentation with a bioinductive implant with a strong recommendation, which is very unusual for the Academy to provide that type of recommendation because it was based on the science. There's tremendous, randomized controlled trials demonstrating improved healing. I mean, for our listeners, I say this all the time, but we really weren't very good at rotator cuff surgery. I mean, we were all doing it and we were all, hoping for the best, but, 60% success, 70% success, 30% failure rates. I mean, it wasn't very confidence building. So now there's new ones on the market too. It seems like, every single medical device company now has some sort of a biologic implant that they are using, whether one's synthetic, whether it's dermal skin, whether it's collagen, whether it's hyaluronic acid derivatives, whether there's strength in the implant versus just using biologics, whether you're putting it on the top or whether you're putting it on the bottom. There's a lot of information that's out there at this point. So I always say, when you talk to your surgeon about these things, do what's the surgeon's comfortable doing, right? You don't want to go to a doctor asking them to use an implant they're not familiar with. So take the time to investigate that and ask them what are their thoughts about these biologic implants to improve rotator cuff healing or ACL healing for that matter.
Don, how would you respond to that question?
Yeah. So I started with the patches and surgical augmentation with a company back then. Wright Medical came out with a dermal graft called Graft Jacket, and my mentor, Dr. Schneider, we had a conversation like, hey, I think this is something that's really going to help strengthen repairs in these tough cuffs, and at that point, the surgical technique was an mini open incision, and so. With the way that the three of us work, why can't we do this through the scope? And so that's what we started working on, was an arthroscopic way. And, back then it was a 2-stage, you guys got a kick out of this. It was 2 surgeries. We would clean up the cuff and do everything, maybe a little bit of repair, but we would have to come back like the next week or 2 weeks later to put in the patch because we didn't want to be in the OR for 5 hours. And now we're getting these done in an hour and a half. So the progression in a couple of decades has been fantastic. And then the Regeniten came out, which is a great bioinductive implant and now has tons of data. And the only knock on the Regeniten back in the day was, it wasn't structurally strong. It was a great bioinductive thing, very successful. And the progression of that was, well, if it's not strong enough, how do we make it stronger? And I guess it was about 4 or 5 years ago that another implant came out that was basically collagen plus basically rebar, PLLA fibers that gave it strength. So now we can suture it and we can deliver it in a way that gives strength to the repair at time 0. And so that has now become, that BioBrace implant has now become kind of a go-to soft tissue augmentation. But like Scott said, surgeons are going to grow up and practice with different implants. And now, as long as we understand what we're trying to do and how to best kind of deploy these things, then I think the impact has been fantastic. The AAOS has recognized it. I would point out that there's far more level 1 studies for PRP for knee arthritis than there are for patches for rotator cuff repair. So I'm hoping one of the next CPGs is for PRP for knee OA with a strong recommendation for pain and dysfunction. But I'm so glad to see our academy moving in the direction of biology because it's the fastest growing part of orthopedics.
I think biologics are great. I mean, I have one of these patches in my own shoulder, and it's been one of the best things I ever had done. And that's changed my life. I restored my lifestyle. I restored what I could do. I was more active with my family. I was more active in sports and working out, things I couldn't do because my shoulder hurt so much. So now to think that, wow, biologics was something that not only do I do for patients, but I had it done for myself, should show our listeners that these things are effective. These things are helpful. What is the ultimate goal here? I mean, I want to go to the future. What is our goal here? Are we going to get to a place where robots are doing surgeries and they're putting in biologics and we don't have to do joint replacements anymore? I mean, is that fiction? Is that something that's coming? Is there going to be a shot that we put in a shoulder and magically the cartilage comes up? And I mean, what do you say to that, Don?
Wow, it's such a great thought question. My own thought on that starts with what we know we can do now. So when patients come in and they've been around the internet and they say, I want to get a stem cell injection, how many grades better will this make my knee? Will I go from grade 4 back to grade 2? The guy down the street's promising I'm going to get an x-ray that looks like a normal knee in 6 weeks. And we know that's not really accurate with what we have now. But what about the patient that we all have that's 21 and blows out their ACL and we do a great repair or reconstruction, and 20 years later they come back to see us if we're still around, and now they're late 30s, 40, and they have KL2-3 changes, and they're starting to have symptoms from arthritic changes. Well, maybe the intervention to do is not then, but maybe every 3 or 4 years after the ACL, we do something in the office that takes 30 minutes, and we prevent that long ongoing catabolic breakdown of their cartilage by doing just a relatively simple biologic intervention at a predetermined interval. So I'm all about looking farther and farther upstream and prevention. And that includes nutritional optimization and all the other things too, and activity and motion. But it really does seem to me that our best chance right now is to pay attention earlier in the catabolic process. We know that bone marrow concentrate, for example, can essentially heal bone marrow lesions. We've got AVN data that shows that AVN is, if you catch it before there's structural collapse, that AVN is reversed. We know that in the shoulder, when you put bone marrow concentrate into the greater tuberosity, it significantly improves your outcomes. And so before we get, 70% of the population getting these degenerative full thickness cuff tears, maybe in 50s or 60s with the first onset of symptoms, we put BMC into the greater tuberosity to prevent that. Because we know that over time, arthritic shoulders lose stem cell concentrations in the bone. So what if we keep those concentrations at a certain level? Maybe we don't have that downstream problem anymore.
Scott, you were scribbling something. What is it you want to say?
Yeah. So the Smart Medicine podcast, which I host as well, I have some really amazing people that have come on and really talked a lot about these topics, Sharif, that you bring up. So, for example, in the oncology world, CAR T-cell therapy now has revolutionized how oncological care is received. So they can identify the cancer cell and then through that immunology, then take out the patient's own T cells and then put in an attacker on it so that this will go in and then kill the cancer cells instead of killing the normal cells. So let's think about that as a delivery system. As Donnie was saying, maybe we can put a chondrocyte in there that can create a healing response to the cartilage. We're going to use AI for genetic profiles or genetic predispositions to osteoarthritis, for example. Can we identify the gene complex and then can we create modalities that will affect and change that gene complex that's making cartilage not go right? When we talk about PRP, well, PRP has 1,500 growth factors in there or messages. It's like we're shooting off this shotgun pellet, and probably a couple of those pellets are the things that are really doing it. So maybe Big Pharma is going to identify those pellets, right? And then maybe it's going to be a pill where we can identify you take this pill and it's going to help to reduce the inflammatory component of arthritis. So I'm very bullish on the future of us as surgeons really moving away from the knife and really, creating a very different healing response for our patients moving forwards.
Yeah, I couldn't agree more. I think, I don't want to say we've reached the limit of what we can do operatively. I think there's still more to come for that, but I think we've looked far past this part of medicine, which I think will eventually catch up. And when it catches up, I think it's going to be very exciting. One of the things that I will ask you, though, and Don, why don't you take this one? What do you do for the patients that is living in the future but is coming to see you now? And I mean, they tell you, my friend had a PRP injection and their knee regenerated. They have all new cartilage. Their doctor told them they've never seen anything like it. But, that's not reasonable. We both know that. I mean, I've flown on enough flights where I look at the magazine and it would show you like a really arthritic knee, and then after they put this whatever injection in, it looks like a brand new knee. And so patients come in with some expectations that may not be realistic. How do you manage that?
Yeah, probably maybe a decade ago, for sure, I talked more people out of biologics than into it. I think the information available online when people kind of do their own research is starting to catch up, or there's fewer of those people that come in that have such wild, fantastic expectations that we have to really spend most of the first visit just talking about what we can and can't do. But I really go to school with them. I have a whiteboard, now a digital whiteboard in this new office, where I lay out all of the potential surgical, if appropriate, and non-surgical options. And particularly in the biologic section, I want them to know the best data we have for their indication. And it is all about education, or in some cases, re-education. So they have proper expectations, because in most of these situations, I want people to understand that just like surgery, there's a chance this may not work. These are not magic injections. These syringes aren't full of magic pixie dust. These are things that, we've done enough of these that we have an idea of the range of outcomes and the range of patients where it may be appropriate, but we're still not omniscient. So oftentimes I will pull up a website with a patient. They'll say, well, I went to this place, or I looked at this place. Can you look at this with me? And that's why these visits take 30 minutes. I'll go through and look at it with them and give them my opinion on what they're basing their opinion on. Facebook and the chat groups and Reddit can be great, or they can be absolutely horrible, And sometimes I'll swim through those just to see what's being talked about. And I just have to close the computer and walk away for a minute because sometimes it gets to be pretty fantastic. And we all know that the placebo effect is so strong. And if you charge people money for something, the placebo effect's even worse, even higher. And so we have to account for that. And I make sure the patients fully understand all that. And it really is about education and giving them, reputable sources if they want to do their own research.
The part that I think might be frustrating, at least for me, is the term that follows biologics in this regenerative medicine landscape. And I don't like that word because we're not regenerating anything. But let's conclude a little bit. Like, what do you want to see as the future goes on? We kind of hit on that, but if you were to leave us with a couple sentences of, let's talk a little bit like what research do you want to see? And then kind of what do you want that takeaway conclusive sentence to our listeners and patients? What is it that you want to add? So Don, I'll start with you.
Well, I'll tell you what I'm working on now. Again, it's that whole theme of, again, spent a lot of years training to be a surgeon, still love being in the operating room. But if I can help even more people by getting them better before getting into the operating room, then I'm interested. And so one of the things that should be coming out published in the first quarter of 2026 is a study that should have the longest follow-up on using bone marrow concentrate for partial thickness rotator cuff tears. And so this is a orthopedic condition that for a lot of people, if they continue to be symptomatic, we take them to surgery, we use something like one of the patches like Scott just mentioned. But what if we could, under ultrasound guidance, inject that defect, not only see it, but inject it with bone marrow concentrate to get a regenerative response, which would be appropriate. And so we've got 7.5-year follow-up. It's a pilot-sized study, 25 patients, about an 80% success rate over 7.5 years, not going to surgery. And that kind of earlier intervention in the disease process is what I'm very interested in. So I'm excited to see that come out and see what you guys think about it. We're photoactivating PRP when we use it for knee arthritis. We've got about 80 people in that study right now, just to see if that gives a different outcome. It's a randomized control trial. And that's, again, all designed to try and either find the proper dose, proper response, proper interval between treatments, or earlier, how early can we intervene and get patients a good response. So that's what I would love to see as we continue to do clinical research and bring these new interesting biologic options to patients.
Yeah, I think what you just said is so important because I don't think we know what the dose is yet for some, because is the dose for arthritis of the knee the same as for, tennis elbow or something like that? And so I think Scott hit it earlier. We do more of a shotgun approach, and hopefully there's enough of something in there to do what it needs to do. I think we understand how it works, but I think we don't have the exact recipe for each individual pathology that a patient may have. So we appreciate that you're doing that research because I think it is going to be something that as the future comes, we're going to need to know, just like grandma's, recipes for the foods that we love, we're going to have Donnie's recipes for lateral epicondylitis and knee arthritis. Scott, how do you want to leave our listeners today?
Well, I just want to jump on one comment that Donnie had mentioned. Rowan Paul and Steve Sampson have done some really good work with photobiomodulation, with PRP, showing enhanced efficacy. So I'm very excited to see what your results will be coming out of your study, Donnie. So Donnie's talked about early intervention. Let me take on surgery, right? What are some of the things in the biologic space for surgical? I think for me, the perfect world would be for more surgeons to start thinking about a holistic approach to the surgical healing process that we do. It's not just the 45 minutes of the surgery where you're doing this operation. We're going to do perioperative nutrition to really sort of bump things up to give patients the best opportunity to heal. Appropriate pain management so the patients can start early range of motion and movement and healing in the process without becoming addicted to medications. And there's some great new FDA oral pain medications that are available now. We're going to use biologic implants to stimulate the human body to create a biohack to really encourage the body to heal itself. We're going to use additional modalities after the surgery to create healing. Again, we talked about photobiomodulation therapy for early intervention, but we're also using photobiomodulation therapy postoperatively to reduce inflammation and pain. So very exciting potential data on all of these ways that we're going to stimulate the human body to create a healing response.
You guys are smart. So you said a lot of big words, and I hope that makes our listeners want to keep doing research on their own or come see us as orthopedic surgeons to help them with their biologic questions. So, in conclusion, I'm Sharif Bechet, and you've been listening to the new Ortho Info podcast, where we answer your questions about musculoskeletal conditions and care. I'd like to thank our guests, Dr. Don Buford from Texas and Dr. Scott Sigmund from Massachusetts, for helping us understand what biologics are and whether they might be right for you. We hope you enjoyed our conversation today and will join us on future episodes. Thank you, gentlemen, so much for joining us today.
Appreciate you, boys. Great work.
Yeah, thanks.
This has been the Ortho Info Podcast, brought to you by the American Academy of Orthopedic Surgeons. Production and editing by MK Quinn Media. You can find the Ortho Info Podcast on orthoinfo.org and wherever you get your podcasts. Like and subscribe so you won't miss new episodes, and visit the Ortho Info YouTube channel for full video podcast episodes and shorts. The views and opinions expressed by guests are their own, and their appearance on the podcast does not imply an endorsement of them or any entity they represent by the AAOS. Reference to any specific product, device, or service during this podcast is for educational purposes only and does not constitute endorsement or recommendation by the AAOS. Ortho Info, expert musculoskeletal health information provided by surgeons, trusted by patients.